Hello, this is Dr. Christine Sykalo, and I would like to present a case of tricky papillary muscle rupture sequelae navigated by evidence-based therapies. I worked on this case with my colleagues Drs. Herrera, Adams, Kumar, and Rojas, and we are all from Northeast Georgia Medical Center in Gainesville, Georgia. Papillary muscle rupture is a dreaded complication that occurs in 1% of patients 3 to 7 days after an acute myocardial infarction. This frequently leads to cardiogenic shock, with mortality rates as high as 80%. Many patients who would otherwise be surgical candidates are too acutely ill to undergo surgical intervention. Fortunately, extracorporeal membrane oxygenation, also known as ECMO, offer patients life-sustaining therapy while awaiting optimization for definitive surgical intervention. Our case is of a 43-year-old male with a past medical history significant for morbid obesity, hypertension with medication non-adherence, and tobacco abuse who presented with complaints of worsening dyspnea for 2 days. During initial diagnostic workup, the patient experienced worsening respiratory distress, tachypnea, tachycardia, and shock. He was hypoxic and required mechanical intubation. Pulmonary embolism was excluded, but the patient developed elevated cardiac markers and troponins of 1.78 with no ST elevation on EKG. An echocardiogram demonstrated ejection fraction of 60% with grade 3 diastolic dysfunction and notable mild mitral regurgitation. This was presumed to be a contributing factor to the patient's presentation. The patient's respiratory status continued to decline and he was severely hypoxic despite optimal ventilator settings. Repeat chest X-ray at the time showed diffuse bilateral opacities suggestive of ARDS, or acute respiratory distress syndrome. The patient was initiated on VV ECMO based on the current Extracorporeal Life Support Organization guidelines for adult respiratory failure. While undergoing VV ECMO, the patient developed bradycardia and asystole with return of spontaneous circulation following CPR. Follow-up EKG noted evidence of new ST depressions in the anterior lateral leads. Given the new cardiac findings, a repeat transthoracic echocardiogram was obtained, demonstrating severe prolapse of the posterior mitral leaflet with ruptured posterior medial papillary muscle, mild prolapse of the anterior mitral leaflet, whole systolic mitral valve prolapse, and severe regurgitation. While awaiting mitral valve replacement, the patient suffered a ventricular fibrillation arrest. Circulation was reestablished and patient underwent arterial cannulization for VA ECMO based on ELSO guidelines for adult cardiac failure, as he met criteria for cardiogenic failure. His blood pressure, tachyarrhythmia, and oxygen saturation stabilized, and he underwent mitral valve replacement successfully. An Impella was placed for a total of 6 days. His oxygen requirements improved over time, and he was weaned off mechanical ventilation to nasal cannula and eventually discharged to a rehabilitation facility. The patient's X-ray here demonstrates worsening pulmonary edema with evidence of his tracheostomy tube, feeding tube, chest tube, internal jugular central line, ECMO catheter, as well as Swan-Ganz catheter. For the discussion, I would like to focus on the Extracorporeal Life Support Organization guidelines and how they were able to support our patient. For VV ECMO, patients with a Murray score of 2 to 3 have an associated mortality of 50%, and VV ECMO should be considered. Patients with Murray scores greater than 3 are required to have VV ECMO. Our patient had a score of 2.8 and thus VV ECMO was initiated. This case illustrates papillary muscle rupture and using ECMO as a bridge to definitive surgical intervention. Relying on evidence-based medicine for each modality despite its complexity optimized this patient's chance for recovery. Thereby, we demonstrate a complex case of PMR, secondary to myocardial infarction with complicated course involving multiple arrhythmic arrests where successful VV and VA ECMO resuscitation afforded bridge therapy to definitive surgical management. It highlights the importance of an interdisciplinary team approach and physician persistence through direction of evidence-based medicine, which is certainly pertinent in the current medical environment. Thank you.